Welcome to the Deep Dive, where we take these incredibly dense clinical texts, all the detailed research, the tough ethical questions, and we really try to distill it all down to the critical knowledge you need. Today, we're journeying into two fields that are, well, they're profoundly linked, but we so often look at them separately. Chronic pain management and the comprehensive world of palliative care.
It is a huge landscape. I mean, the sources we're pulling from today, they go from the cellular level, literally how a single nerve fires, all the way up to these really sophisticated, tough decisions at a patient's bedside.
So what's the goal for us today?
I think it's precision. Our goal is to synthesize all of this and really get to the core of why pain persists, the actual biology of suffering, and then show with the evidence why managing it effectively, well, it absolutely has to be holistic. It has to be what we call a biopsychosocial approach.
That phrase is so important. So we're going to start at the absolute foundation, right? The basic biology of pain. We'll trace that electrical signal from the first moment of an injury all the way up to how the brain experiences it.
Yep.
Then we'll get practical. We'll move into clinical assessment, the tool that helped doctors see this invisible thing called pain. We'll look at interventions, everything from exercise to some pretty advanced pharmacology.
And then the big pivot.
Right. And finally, we make that really critical shift into the specialized world of palliative care, end-of-life symptoms, and all the ethical thinking that has to guide comfort and dignity at the end.
Let's do it.
Okay, so let's start with the absolute basics, the definition of pain itself, because the official one, it immediately tells you we're talking about so much more than just, a physical sensation.
It does.
The definition in our material calls pain an unpleasant sensory and emotional experience associated with actual or potential tissue damage.
So when you put that emotional experience part front and center, how does that fundamentally change how we should be approaching a patient?
Oh, it changes everything. I mean, for centuries, pain was just seen as this simple mechanical thing.
Yeah.
You get damage, you get a sensation, end of story.
Right, like a wire connected to a light bulb. Exactly. You can go all the way back to Hippocrates around 450 BC, and the theory was just that pain was an imbalance of fluids. But this modern definition, it forces us to see that pain is this incredibly complex, subjective thing. It's shaped by your social life, your culture, your emotional state, even your past experiences.
So when a patient says their pain is an 8 out of 10,
you have to treat the entire context of that 8 out of 10. You can't just treat the tissue damage that you think might be causing it.
And within that context, the very first most important split is between acute pain and chronic pain. They are functionally just night and day.
Oh, completely. Even if the sensation might feel similar to the patient, acute pain is. It's protective. It's a highly functional alarm system. It tells you to pull your hand off a hot stove or to rest a broken leg.
It's useful.
It's incredibly useful. It prevents more damage. But chronic pain, that's pain that sticks around long after the normal healing time. Usually we say about 3 months. And the sources are, completely firm on this. Chronic pain serves no useful function. It's a disease in and of itself. It becomes this pathological state that causes just catastrophic distress.
So the alarm bell is just stuck ringing long after the fire is out. The system itself has become the disease.
That's it, exactly. And this leads us right to the foundational idea for understanding this whole mess, the biopsychosocial model.
Which is really the roadmap for all of modern pain management.
It is. It moves us completely away from a purely biomedical view. It says that the pain you feel isn't just one thing, it's this dynamic, integrated experience that comes from 5 major factors, all feeding into each other.
Okay, let's unpack those 5 layers for everyone listening, starting with the most obvious one, the physical.
Okay, so first, you have the sensory inputs. This is the hardwiring, your genetics, your anatomy, the actual or nerve signals coming in. But that signal is immediately filtered through layer 2. Cognition.
Our thoughts about the pain.
Yes, exactly. What are you thinking about your pain? Are you using positive coping strategies, or are you catastrophizing?
That's such a powerful word. Catastrophizing isn't just my back hurts. It's this pain means I'm going to be paralyzed and my life is over.
Precisely. And that cognitive loop, the rumination, the magnification, it physically fuels the pain experience, even if the sensory input from the back isn't changing at all.
Okay, so that's 2 layers.
Layer 3 is affect and emotional state. This is your mood, anxiety, depression, and really crucially, your sense of self-efficacy. Your belief that you can actually do something to manage your pain. If you feel helpless, the pain signal gets amplified.
And the last 2 layers bring the outside world in.
They do. Layer 4 is social and cultural factors. your socioeconomic status, your family support, even your religious beliefs about suffering. All of these can totally change how pain is felt and expressed.
Right.
And finally, layer 5 is the underlying disease and illness behavior. And a huge part of this is something called fear avoidance.
Where the patient starts to think that any activity will cause more damage, so they stop moving altogether.
Exactly. And that leads to deconditioning, more weakness, and surprise, more pain. It's a vicious cycle.
So when you look at it like that, trying to treat chronic pain with just a powerful pill, it's like trying to knock down a 5-story building by kicking the front door.
It is. If you ignore their cognition, if you don't address their fear of movement or their belief that the pain means something terrible, you're fighting against these deep psychological patterns that are fundamentally making the pain worse.
Okay, let's go deep into that wiring. When an injury happens, what determines if we feel a sharp, immediate sting versus a deep, dull ache? Our source material talks about different types of nerves.
Yeah, and this anatomy really explains the different qualities of pain. You basically have two main types of fibers sending the signals. First, you've got the myelinated fibers, mostly the A delta fibers.
Myelin being the insulation on the wire.
Exactly, the fatty sheath that lets the signal travel super fast. These A delta fibers are the high-speed internet connection. They transmit that immediate, sharp, well-localized pain. It's the ouch when you stub your toe.
The warning signal.
The initial warning. In contrast, you have the unmyelinated fibers, or C fibers. They don't have that insulation, so the signal is much, much slower. They transmit that diffuse, throbbing, poorly localized ache that comes after the initial sharp pain. That's the lingering ooh that follows the ouch.
So let's trace that signal. It starts at the injury, and then it heads for the spinal cord.
Right. The signal begins at these specialized bare nerve endings called nociceptors. They're all over your skin, your muscles, and they get activated not just by pressure, but by chemicals that are released when tissue is damaged, things like prostaglandins, bradykinin, or even just a change in pH. That signal then travels up the nerve to the dorsal horn of the spinal cord. And this place is critical. It's the first central synapse. It's the first big junction box.
And it's not just a simple relay station. This is where the message can be turned up or turned way down, right?
That is the absolute key. This is the first major site of pain modulation. The volume knob is here. The incoming message is heavily influenced by local neurons and, really importantly, by descending signals coming down from the brain.
So the brain can tell the spinal cord to quiet down.
It can. The final signal that gets sent up to the brain depends on the chemical balance right there in the dorsal horn. You have powerful inhibitory forces trying to quiet things down, neurotransmitters like GABA and glycine, and you have powerful excitatory forces trying to amplify the signal, mainly glutamate and substance P.
And in a healthy system, there's a balance. But in chronic pain, that balance is just gone.
It is completely tipped in favor of excitation. And that's where a lot of our drugs, especially the anti-neuropathic ones, are trying to work right there, trying to restore that delicate chemical balance.
Okay, so that signal gets through the spinal cord. Where does it go next to create the actual feeling of pain?
Well, the second set of neurons takes that signal up to the brain, specifically to the thalamus, which is like the brain's central relay station. From there, it gets sent out to multiple areas, the sensory cortex, so you know where it hurts, but also the amygdala for the emotional response, the fear, and the frontal lobe for the cognitive part, the meaning you attach to it.
And the integration of all of that is what the sources call the pain neuromatrix.
Exactly. It's the brain creating the reality of pain. And crucially, the signals flow both ways. It's called top-down regulation. Your mood, your focus, your expectations, they can actually send signals down to the spinal cord to block the incoming pain message.
So like the classic example of a soldier who doesn't feel a major injury on the battlefield?
Perfect example. Their brain is so focused on survival that it's sending powerful inhibitory signals down. But in chronic pain states, that system breaks. We often lose that natural descending inhibition, which makes us much more vulnerable.
And the process that locks all of this in, the thing that makes the system stay broken, is sensitization.
Sensitization is the name of the game in chronic pain. It's neuronal plasticity, the nervous system's ability to adapt, gone wrong. It adapts in a way that leads to these prolonged, debilitating changes. And we can break it down into two types.
Okay.
First, there's peripheral sensitization. This happens right at the site of the injury. So you have inflammation, and that releases a chemical prostaglandins, all those mediators we mentioned. These chemicals actually change the nociceptors themselves. They lower their activation threshold.
So it's like turning up the sensitivity on a microphone.
Perfect analogy. Now, light touch that would have been ignored before triggers a full-blown pain signal. That's why an injured area is so tender. But the really big one for chronic pain is central sensitization.
And this happens in the spinal cord.
Right, at that first synapse we talked about. It happens in response to a sustained barrage of pain signals from the periphery, a chronic infection, a long-term injury. And the mechanism is fascinating. It's all about a neurotransmitter, glutamate, and a specific receptor called the NMDA receptor.
I've heard of this one.
So normally, this NMDA receptor is kind of silent. It's physically blocked by a little plug, a magnesium ion.
Okay, so what happens when that constant barrage of pain signals hits the spinal cord?
That constant input causes a massive release of glutamate.
Yeah.
So much that it physically pushes that magnesium plug out of the receptor.
It unplugs it.
It unplugs it. And once it's open, it allows a flood of calcium into that spinal cord neuron. And that flood of calcium is the trigger. It sets off a cascade of changes inside the cell that leads to a prolonged structural modification of how that neuron processes information.
So it's not just a temporary signal anymore. The cell itself has been reprogrammed.
It's been fundamentally altered. This is the cellular basis of memory, a process called long-term potentiation, but it's become pathological. The neuron is now hyperexcitable. It leads to something called after discharge, meaning the neuron keeps firing and sending pain signals up to the brain even after the original injury has completely healed. The pain is now self-sustaining. It's being generated centrally in the spinal cord, independent of what's happening in the body.
That one idea, the unplugged NMDA receptor causing this after discharge, that seems to be the absolute key to why chronic pain just doesn't go away.
It is. It's the ultimate proof that the nervous system can create pain all on its own. But we also have to remember that some people are just more vulnerable to this than others, and that brings us to the huge role of genetics.
Right. How much of this is just wired in from birth?
The estimates are pretty striking. The heritability for things like chronic widespread pain is thought to be between 30 and 50%. And while most of it is a complex mix of many genes, researchers have found these rare single-gene disorders that just dramatically affect how you feel pain.
Like the ones that affect the sodium channels that carry the signal.
Exactly. The gene SCN9A is the classic example. It codes for a specific sodium channel. If you inherit a mutation that makes the channel not work at all, you literally can't feel pain. You could break a bone and not know it.
And the opposite.
If you get a gain-of-function mutation, the channel is hyperexcitable. And that leads to these horrible, lifelong burning pain syndromes. It just goes to show how a tiny change in one molecule can completely dictate a person's entire experience of pain.
Okay, let's move into the clinic. We've got this incredibly complex, emotional, genetically variable problem. So when you're managing it, the goals have to be about more than just getting the pain score to 0.
Oh, absolutely. Chasing a score of 0 is often unrealistic and can lead to really poor outcomes. The 5 core goals are actually, first, to educate the patient. Then, promote self-management. Third is to optimize function, get them back to doing what they value. Fourth, enhance quality of life. And then fifth is to control pain.
So controlling the pain is actually last on the list.
It is, and that's intentional. The focus is on function and self-efficacy.
And to get there, you have to do that full biopsychosocial assessment, which I imagine takes a lot of time.
It does take time, but it's an investment. It validates the patient's experience, and it gives you the roadmap for treatment. You need the basics duration, what makes it better or worse, but critically, you need the qualities of the pain.
You mean, like, is it sharp or is it dull?
Exactly. Is it dull and aching?
Yep.
That suggests a more nociceptive tissue-based problem. Or is it sharp, shooting, burning, electric? That screams neuropathic, that screams sensitization.
So the words the patient uses are the first clue to what's happening biologically.
It's the clinical translation of the neurobiology. And beyond that, you have to document the functional impact. How much does this pain interfere with your sleep, your work, your life? And then, of course, the psychosocial layers. You have to screen for depression, assess their social support, and always, always assess for suicide risk.
And you mentioned earlier that if you don't get at what the patient believes about their pain, the whole treatment can fail.
100%. You have to ask, what do you think is causing this pain? And what are your expectations from treatment? If a patient secretly believes their chronic back pain is a sign of cancer, no amount of physical therapy is going to work until you address that core fear. That conversation about their beliefs is part of the treatment.
Okay, so once you have that whole story, you move to the physical exam.
Hmm?
Are there simple bedside tools you can use to actually test for things like allodynia, those signs of sensitization?
Yeah, we have some very standard sensory testing tools. To check for allodynia, where a non-painful stimulus feels painful, you use something soft, like a cotton ball or a little brush. You gently stroke the affected area. If they say, ow, that's painful, that's objective evidence of central sensitization.
And for other things?
We use a sterile pin to test for mechanical hyperalgesia, an exaggerated response to a pinprick. And we have these little thermal rollers, one warm and one cool, to check for abnormal temperature sensation. You always test the affected area and compare it to an unaffected area on their body to get a baseline.
And what about things like imaging? When is an MRI useful and when is it not?
For very focal pain that follows a clear nerve route, an MRI can be great for finding a structural problem like a disc herniation, but for widespread, chronic pain, an MRI is often completely unhelpful. It can even make things worse if it finds some minor age-related change that the patient then catastrophizes about.
So what's a more targeted diagnostic tool?
A nerve block can be incredibly useful. You inject a short-acting local anesthetic, like lidocaine, near the nerve you suspect is causing the problem. If the pain goes away completely, you know the source is likely peripheral. If the pain doesn't change at all,
Then the problem is central. It's in the spinal cord or the brain.
exactly. It
Yeah.
tells you that peripheral treatments are probably going to fail and you need to focus on central acting medications.
Beyond just finding the source, you need to quantify the impact. And that's where all these pain scoring systems come in. But a simple 0 to 10 scale doesn't tell the whole story.
It really doesn't. It only tells you severity. The better tools quantify impact. The Brief Pain Inventory, or BTI, is a great one. It asks you to rate not just your pain, but how much it interferes with your general activity, your mood, your relationships, your sleep.
And you have to screen for the psychological side, too.
Oh, absolutely. We use tools like the Pain Catastrophizing Scale, which measures how much a person is ruminating or feeling helpless about their pain. High scores on that scale are a huge red flag and a strong predictor of poor outcomes. And another one is the Tampa Scale of Kinesiophobia, which specifically measures the fear of movement.
So you can target your physical therapy to overcome that specific fear.
Precisely. These tools make that big, abstract biopsychosocial model measurable and actionable.
Now, this assessment gets so much harder with vulnerable populations. Let's take pediatric patients, for example. How do you get an accurate pain score from a 4-year-old?
Yeah, you have to use tools that are appropriate for their developmental stage. You can't ask a 4-year-old to rate their pain from 1 to 10, so we rely heavily on visual scales, like the one with the different faces, from a happy face to a crying face. The child can just point to the face that shows how they feel.
And what about the older adult population? They come with a whole different set of risks.
A huge set of risks. They're often on multiple medications, so their risk of side effects is much higher. Their metabolism might be different. They could have some baseline cognitive impairment that makes assessment tricky. And there are often cultural factors where they just don't want to complain or be a burden, so they underreport their pain. You have to be incredibly proactive with that group.
When a patient has severe cognitive impairment, like advanced dementia, and they can't speak for themselves, what do you rely on?
You have to become a detective. You rely entirely on nonverbal observational cues. You look for subtle changes. Is their facial expression different? Grimacing? Are they guarding a part of their body? Are they more agitated or restless than usual? Are they suddenly withdrawn? It takes a lot of training because often that pain gets missed and just labeled as agitation.
And finally, the population with a history of substance misuse. This requires a very specialized approach.
It really does. With these patients, you often see increased tolerance to analgesics, so standard doses might not work. And there's obviously a much higher risk of addiction and diversion of medication. Management absolutely requires specialist support from a pain or addiction team. Prescribing has to be incredibly careful, often with written contracts and very clear rules.
Okay, so the assessment is done. We have this rich, complex picture of the patient's pain. Now we move to intervention. And we start not with a prescription pad, but with something called supported self-management.
Yes, the goal here is empowerment. It's about shifting the focus. It starts with helping the patient understand and accept that the pain signal might never be completely gone. So the goal isn't to erase the pain, but to maximize your function and your quality of life with the pain.
So what does that look like in practice? How does it actually help?
A key strategy is pacing. So many patients with chronic pain get into this boom and bust cycle.
I think I know what you mean.
They have a slightly better day, so they try to do all the housework, all the gardening they've been putting off, and then they have a massive flare-up and they bust. They're stuck in bed for 3 days, totally deconditioned.
Right.
Pacing breaks that cycle. It's about figuring out a sustainable baseline of activity and sticking to it, doing a little bit consistently rather than overdoing it and crashing.
And this must also help with that fear avoidance we talked about.
It's the core of overcoming it. The evidence is just overwhelming that graded exercise programs are essential for chronic pain. The therapy is structured to reintroduce movement slowly, in a safe way. It proves to the patient through their own experience that movement doesn't equal more damage. That cognitive shift is often more powerful than any drug.
So when we do finally bring in the drugs, the sources are adamant that it has to be a multimodal approach. Why is combining different drugs so important?
Because, as we've seen, chronic pain has multiple mechanisms. You've got inflammation, you've got nerve signals, you've got central sensitization. So a multimodal approach targets several of those pathways at once.
So you're attacking the problem from different angles.
Exactly. And the huge benefit is that you can use lower doses of each individual drug. That dramatically cuts down on the side effects compared to just cranking up the dose of one powerful medication.
And we always have to remember that a person's genetics will determine how they even respond to these drugs.
Absolutely. That genetic variability is massive. We mentioned CYP2D6, the enzyme that metabolizes codeine. If you're a rapid metabolizer, codeine could hit you way too hard to be dangerous. If you're a poor metabolizer, it might do absolutely nothing. And knowing this helps us understand why one patient gets great relief and another gets none from the same pill.
Let's run through the main classes of drugs, starting with the most common one, paracetamol or acetaminophen. How good is the evidence for it in chronic pain?
You know, for something so widely used, the evidence for chronic musculoskeletal pain is surprisingly weak. It's useful for a headache, maybe some mild acute pain, but for chronic low back pain or osteoarthritis, the sources say there's very little high-quality evidence that it's any better than a placebo.
And it's not without risks.
Definitely not. There's a real risk of liver damage, even at recommended doses, especially in older patients.
And what about NSAIDs like ibuprofen or naproxen?
NSAIDs are great for inflammatory pain. If you have a flare of arthritis, they can be fantastic because they block prostaglandins. But you can't use them long-term for chronic pain because of the significant cardiovascular and kidney risks. They're a short-term tool, not a long-term solution.
So let's talk about more targeted approaches like topical analgesics. These seem like a much safer bet.
They're a brilliant example of targeted multimodal therapy. The lidocaine 5% patch is a good one. It's a local anesthetic, so it blocks the sodium channels in the nerves right under the patch. It just quiets down the peripheral signals before they can even get to the spinal cord.
Right.
But the capsaicin patch is even more interesting. Mechanically, this is a high-dose patch of the stuff that makes chili peppers hot.
So you're putting a chili pepper on the painful area.
Basically, yes. It causes this initial intense burning sensation, but what it's doing is overstimulating a specific ion channel on the C fibers, the TRPV1 channel. And after that initial burn, it causes the nerve endings to become desensitized. It actually causes a temporary, reversible reduction in the number of nerve fibers in the skin.
So you're essentially doing a temporary, targeted denervation.
Exactly. And one application can provide pain relief for up to 3 months. It's a really clever way to tackle peripheral sensitization head on.
Okay, now for the heavy hitters for nerve pain, the antineuropathic agents, these are the drugs that try to rewire the central nervous system.
They are, and they're essential for any pain that has that burning, shooting quality. But you have to tell patients that they take time. The effect isn't immediate. It can take weeks.
But what's the first-line treatment?
The first line is usually antidepressants, but used for their pain-modulating properties. So SNRIs like duloxetine or older TCAs like amitriptyline, they work by boosting the levels of serotonin and norepinephrine, which enhances those top-down inhibitory signals we talked about, helping the brain quiet the pain messages in the spinal cord.
And if those don't work?
Then the second line is often the anti-epileptic agents, gabapentin and pregabalin. They work by calming down hyperexcitable neurons, probably by reducing the release of glutamate.
But the sources raise a pretty big warning flag about those two.
They do. While they can be effective, there is a growing and really serious concern about their potential for misuse and abuse and their association with drug-related deaths, especially when they're mixed with opioids. So there's a lot more caution around prescribing them now than there was a decade ago.
Which brings us to the absolute elephant in the room. the use of strong opioids for chronic non-cancer pain.
The opioid dilemma.
Right. They're powerful pain blockers, but we've seen the devastation of the opioid epidemic.
So for this specific context, chronic pain that is not from cancer, what does the evidence actually say about their long-term effectiveness versus the risk?
This is probably the most contentious area in all of pain medicine. And the evidence, when you look at it clearly, is just crushing.
Yes, the bottom line.
The bottom line is there is very limited evidence for any short to medium-term benefit, and more importantly, the longer-term evidence shows no improvement in function, and in many cases, it shows worse pain over time.
Worse pain.
Yes. The idea that putting someone on high-dose opioids for years for their chronic back pain is going to improve their quality of life, it's just not supported by the data. The harms almost always outweigh the benefit.
And the list of harms is long.
It's very long. Beyond the obvious risks of addiction and overdose, we see major issues, especially at higher doses. Things like endocrine dysfunction, much higher risk of fractures from falls, and bone density loss, and this really terrifying condition called opioid-induced hyperalgesia, where the drug that's supposed to relieve pain actually makes you more sensitive to pain.
It's a complete biological paradox. The chronic use of opioids can actually cause changes in the central nervous system that amplify pain signals. It's another form of that maladaptive plasticity. The patient ends up in a state where they need more and more opioid just to function, while their underlying pain sensitivity is getting worse and worse.
So the clinical guidance now has shifted dramatically towards extreme caution. What are the rules for prescribing now?
Opioids should only ever be considered for a short-term, time-limited trial in a very carefully selected patient. And it should never be the only treatment.
And the trial has to have clear goals.
Clear functional goals. Not get my pain score to 2, but be able to walk my dog for 15 minutes. And you must establish stopping rules before you even write the first prescription.
A stopping rule, what does that mean in practice?
It's a clear, documented agreement with the patient. We will try this for 6 weeks. If, at the end of 6 weeks, you are not meeting your functional goal, or if the side effects are too much, we will agree to slowly taper and stop the medication. It creates an exit strategy from the very beginning and prevents people from getting stuck on them for years with no clear benefit.
Let's touch on a few specific, really severe chronic pain syndromes, starting with the general category of neuropathic pain.
So neuropathic pain is any pain that's caused by a lesion or a disease in the nervous system itself. Think of diabetic neuropathy or the chronic sciatic pain from a compressed nerve root. It is incredibly debilitating.
And what are the classic signs a clinician looks for?
You're looking for a specific cluster of symptoms. Spontaneous pain, that burning, shooting, electric shock feeling that comes out of nowhere. Positive sensory signs like alginia and hyperalgesia. And negative sensory signs like numbness or tingling. If you have that combination, you have to treat it with the anti-neuropathic agents we just talked about.
Okay, what about the really devastating syndrome of complex regional pain syndrome, or CRPS?
CRPS is this rare but horrible condition. It's severe neuropathic pain, usually in one arm or leg, that seems to involve a major dysfunction of the autonomic nervous system. It often starts after a relatively minor injury, like a wrist fracture.
And the diagnosis is very strict based on what are called the Budapest criteria.
It has to be strict. The patient has to have symptoms in at least 3 out of 4 categories: sensory changes, vasomotor changes like skin color and temperature, pseudomotor changes like swelling and sweating, and motor changes like weakness or changes to hair and nails. And a clinician has to see signs in at least 2 of those categories.
And the treatment.
It's intensely multimodal. Early diagnosis is key. It involves intensive physical therapy, desensitization, and this fascinating technique called graded motor imagery, where you basically retrain the brain's map of that limb.
And finally, the very strange and distressing phenomenon of phantom limb pain.
Yeah, this is the experience of feeling pain in a limb that isn't there anymore. It's the ultimate proof that pain is generated in the brain, in that neuromatrix. The limb is gone, but the brain's map of it is still there, and it's firing off pain signals.
How on earth do you treat that?
Well, you use the standard anti-neuropathic drugs.
Yeah.
But you can also try non-pharmacological things like mirror visual feedback.
The mirror box therapy.
Exactly. The patient puts their intact limb in a box with a mirror, so when they look, it appears as though they have 2 healthy limbs. They then move their healthy limb, and the brain gets this visual feedback that the phantom limb is moving normally and without pain. And over time, that can help to reorganize the brain's sensory cortex and reduce the pain.
Okay, let's make that critical pivot now to palliative care. The definitions here are so important, especially the difference between palliative care and end-of-life care.
They are, and they get confused all the time. Palliative care is the active, total care for any patient with an incurable disease. The focus is on symptom control and quality of life. The absolute key is that it can be delivered at any stage of the illness, often right alongside treatments that are trying to cure or control the disease.
So you can be getting chemotherapy and palliative care at the same time.
Absolutely. End-of-life care, on the other hand, is specifically the care provided during the very last phase of life, when death is clearly imminent and the focus shifts entirely to comfort and dignity.
So for palliative care to work well, clinicians need to recognize when a patient's illness is becoming life-limiting. And that's where the idea of illness trajectories comes in.
Yeah, understanding these trajectories is vital for planning and for having realistic conversations. We basically see three main patterns of dying. First, there's the rapid decline, which is typical for many cancers. The patient maintains pretty good function. And then there's a short, predictable period of rapid decline right before death.
The second one sounds much harder to manage.
It is. It's the erratic intermittent decline. This is what you see in advanced organ failure, heart failure, COPD. These patients have periods of stability, and then they have an acute crisis, like a chest infection, that causes a huge drop in function. They might recover a bit, but they never get back to where they were before.
And the challenge there is always knowing when to switch from aggressive treatment to comfort care.
It's the central challenge. The communication has to be constant and incredibly sensitive. And the third trajectory is the poor function frailty model. This is what you see with advanced dementia. The patient can live for years with very low function before a short terminal phase. The challenge there is more about providing excellent long-term nursing care and having clear advance plans in place.
Let's talk about managing pain in palliative care, because the prevalence is just staggering. 2/3 of cancer patients have moderate to severe pain, and the sources point out a huge barrier to good care, using idiosyncratic shortcuts in assessment.
This is a massive clinical problem. The shortcut is the clinician who walks in and just says, "How's your pain today?" And the patient, not wanting to be a bother, says, "Oh, it's fine." And the pain gets documented as a 2 out of 10.
When in reality, it's not fine.
Right. A validated tool forces a better question, like, on a scale of 0 to 10, what was your worst pain in the last 24 hours? And the answer to that question might be an 8, and that's the number you need to treat. Using a structured tool is proven to dramatically improve cancer pain control.
The foundation for treating cancer pain is the WHO analgesic ladder. And it's important to stress this is a very different approach than what we just discussed for chronic non-cancer pain.
A completely different philosophy. The WHO ladder is about using the right strength of analgesic for the severity of the pain. Step 1 for mild pain is a non-opioid like paracetamol. Step 2 for mild to moderate pain is a weak opioid like codeine. And step 3 for moderate to severe pain is a strong opioid like morphine or oxycodone.
And in modern practice, a lot of clinicians are now skipping step 2.
They are. The evidence shows that for true moderate to severe cancer pain, it's often more effective and even safer to just start with a low dose of a strong step 3 opioid, rather than trying to max out the dose of a weak opioid, which often just leads to more side effects with no more pain relief.
Okay, let's talk about how to use those strong opioids. How do you titrate the dose, and how do you manage the inevitable breakthrough pain?
So for continuous pain, you prescribe a regular, round-the-clock dose of a long-acting opioid. But the patient will also have breakthrough pain, these transient flares of severe pain. For that, you prescribe an immediate-release or short-acting opioid. And the standard dose for that breakthrough medication is 1/6 of their total regular daily dose.
And when you're increasing the regular dose, you look at how many breakthrough doses they took. But there's a really critical exception for what's called incident pain.
This is so important, and it gets missed all the time. Let's say a patient took 5 breakthrough doses yesterday. If you look closer and see that 4 of those were for pain that only happened when they moved, like getting out of bed with bone metastases, that's called incident pain. And you generally do not increase their background regular dose to cover that.
Why not?
Because if you do, you'll be massively over-medicating them when they're at rest. They'll be sedated, confused. The background dose is for the pain at rest. Incident pain needs a different strategy, like taking a dose of a very fast-acting opioid right before you plan to move, or using a non-drug approach like radiotherapy for the bone pain.
Right, because not all cancer pain responds well to opioids. What are some other examples?
Bone pain from metastases is a big one. It's often driven by inflammation, so it responds much better to NSAIDs or, most effectively, a single dose of radiotherapy. Another one is liver capsule pain.
From a tumor stretching the liver.
Exactly. That pain responds terribly to opioids. The best treatment is a course of glucocorticoids like dexamethasone to reduce the swelling and inflammation, which takes the pressure off the capsule.
Let's turn to the side effects of opioids. They are almost universal in palliative care, but tolerance develops to some, but not others.
Right. Most patients will feel some nausea or drowsiness when they first start, but that usually gets better in a few days. But tolerance never develops to constipation. So every single patient starting a strong opioid must also be started on a regular laxative regimen from day one.
And what are the signs that a patient is developing opioid toxicity? What are the red flags?
The signs are neurological: vivid dreams or nightmares, visual hallucinations, often seeing things move in the corner of their eye, confusion, delirium, and this thing called myoclonus, which is involuntary muscle twitching or jerking.
And what does that mean?
It usually means that active metabolites of the opioid are building up, which is a huge problem in patients with poor kidney function. When you see those signs, you need to act urgently.
Which brings us to opioid switching. If a patient has bad side effects or their kidneys are failing, what are the safer options?
Morphine has metabolites that are cleared by the kidneys, so it can be dangerous in renal failure. In that case, we switch to an opioid like fentanyl, often given as a patch, or buprenorphine. Their metabolites are inactive or aren't cleared by the kidneys, so they are much, much safer for those patients.
The job of palliative care goes way beyond pain. Let's talk about managing some other really distressing symptoms, starting with breathlessness or dyspnoea.
Dysmenorrhea is terrifying for patients. The first step is always to look for a reversible cause, like a pleural effusion you can drain. But if it's from the advanced disease itself, some of the most effective treatments are non-pharmacological.
Like what?
Teaching pacing, and amazingly, a simple handheld fan. Blowing cool air onto the patient's face, onto the cheeks and nose, stimulates the trigeminal nerve, and that sends a signal to the brain that profoundly reduces the sensation of breathlessness.
And what about drugs? We hear about opioids for breathlessness.
Yes, low-dose oral morphine is highly effective. It works centrally to reduce the brain's drive to breathe, making the sensation much more comfortable. And if anxiety is part of it, a small dose of a benzodiazepine can help break that cycle of panic. The one thing to remember is that oxygen is only helpful if the patient is actually hypoxic, if their oxygen levels are low. If they're not, it provides no benefit over room air.
Okay, what about nausea and vomiting? This seems incredibly complex because you have to match the drug to the cause?
It is complex. You have to think like a neuropharmacologist. There are basically 4 different pathways that can trigger vomiting, and each pathway uses different receptors. So you have to pick the antiemetic that blocks the right receptor for the cause.
So give us an example. If a patient is nauseous because of a chemical imbalance, like from kidney failure or from opioid side effects,
That's stimulating the dopamine D2 receptors in an area of the brain called the chemoreceptor trigger zone. So you need a D2 blocker like haloperidol. But if the nausea is from motion sickness or something vestibular, that's using histamine and acetylcholine receptors. So for that, you'd use a drug like cyclosine.
and this gets really tricky with gastrointestinal obstruction in advanced cancer.
Oh, it's a therapeutic nightmare. You often can't do surgery, so you're managing symptoms. For the cramping pain, you use an anticholinergic like hyoscine. To reduce the amount of fluid and vomiting, you can use a drug called octreotide. But then you have to pick your antiemetic very carefully.
Why?
Because a drug like metoclopramide, which is a prokinetic, is absolutely contraindicated. It will make the bowel try to push against a complete blockage, causing agony. You have to use drugs that don't stimulate gut motility.
Finally, let's touch on cancer cachexia. This isn't just weight loss.
No, it's a complex metabolic syndrome. The tumor itself is releasing inflammatory chemicals that change the body's metabolism, causing profound muscle wasting and a total loss of appetite. You can't just fix it by telling the patient to eat more. Management involves light exercise to preserve muscle and sometimes a short course of steroids to give a temporary appetite boost.
So as a patient is clearly entering their final days or weeks, the focus shifts to planning for dying. What do we know about what patients want in that phase?
Overwhelmingly, patients want honesty. They want to feel a sense of control, and they want a peaceful death, which for most people means dying at home. The clinician's job is to be proactive, to have these conversations early, and to make sure everyone understands the patient's wishes, their advanced directives.
And what are the clinical signs that tell you a patient is now actively dying?
It's a cluster of signs that usually means death is just days away. The patient is bedbound, they're sleeping most of the time, they can't take their tablets anymore, they can only manage sips of water. And crucially, there's no reversible cause for this rapid decline.
Once you make that diagnosis, there's an immediate management shift.
Immediate and total.
Yeah.
The focus is 100% on comfort. You stop all the non-essential medications, the statins, the blood pressure pills, you stop checking vital signs, and you make sure that the essential comfort medications are available in an injectable subcutaneous form. An opioid for pain, an antiemetic for nausea, a sedative like midazolam for distress or agitation, and an antipsychotic like haloperidol for delirium.
One of the most emotional issues at this stage is the hydration debate. Should you give intravenous fluids?
This is so hard for families because they see hydration as basic care, but the clinical evidence is that at the very, very end of life, IV fluids often don't add to comfort. Meticulous mouth care can relieve the sensation of a dry mouth just as well, and giving too much fluid can actually cause harm. It can worsen edema and, critically, increase respiratory secretions, leading to that noisy, rattling breathing that can be very distressing for the family to hear.
And finally, let's address the very difficult ethical question of requests for euthanasia or assisted dying.
Yeah. The key insight from decades of palliative care research is that when a patient asks to hasten their death, it is very often a cry for help. It's frequently driven by symptoms that aren't being managed, well uncontrolled pain, depression, a feeling of being a burden, or a loss of dignity.
So the first response is not to debate the ethics, but to reassess the symptoms.
The first, second, and third response is to go back and do an impeccable symptom assessment. You aggressively treat the pain, the depression, the existential distress, and very often, when that is done well, the request to die goes away. The official position of palliative care organizations is that their role is to support life and relieve suffering, and that euthanasia is not part of their practice.
So to bring this all together, what are the core insights you want our listeners to take away from this deep dive?
I think there are two. First, that chronic pain is a disease of the nervous system itself. It's a state of pathological central sensitization. And because of that, you absolutely have to manage it with a broad biopsychosocial lens that focuses on function, not just on a pill.
And the second?
That palliative care is this incredibly proactive, holistic, and individualized form of care that's about ensuring dignity by anticipating and managing the whole spectrum of symptoms that come with an incurable illness, not just the pain.
And it seems like the common thread through all of this, whether it's a 30-year-old with CRPS or an 80-year-old at the end of life, is that effective care is all about listening. It's about taking the time to understand the patient's full, complex story, their fears, their beliefs, their context, because only then can you actually help them maximize their quality of life.
Exactly. Which brings us to a final thought for you to mull over. We've seen this huge contrast. On the one hand, we have powerful evidence showing the harms and the limited long-term benefit of strong opioids for chronic non-cancer pain. But on the other hand, strong opioids are the absolute ethical, effective backbone of cancer pain management via the WHO ladder.
Right, two completely opposing philosophies.
So the question to think about is this. How might future developments, maybe in highly targeted anti-neuropathic drugs, or a deeper understanding of our individual genetic responses to pain, how might that eventually harmonize these two conflicting approaches and maybe reduce our reliance on opioids across the board while still guaranteeing that no one has to suffer needlessly?